I have a special interest in aplastic anemia. I lead the National Center of Aplastic Anemia at King's, and been doing it since Professor Judith Marsh retired. I can't even remember how long ago, but it's not too long, but a couple of years now. And I also lead the PNH service at King's. I also do other diseases like myelodysplastic syndrome and also stem cell transplant. So all yours, happy to chat. And obviously, it's more of a two-way communication and chat, I think. So because quite a lot of things are not set in stone in this time about vaccination for flu and COVID in aplastic anemia. Just as a bit of a backdrop for people, because there is always a historical backdrop to vaccination in aplastic anemia. This even goes back prior to COVID as a new disease and COVID illness, COVID pandemic, because there has always been a bit of skepticism in the aplastic anemia community for many, many years, because there has been odd cases of vaccine itself triggering relapse of aplastic anemia. And that's one of the big scariest thing for any patient, because you don't want to revisit the diagnosis. And there has been cases reported, but very handful. And unfortunately, in a medical literature, anything which happens like this gets reported. It doesn't report the thousands and hundreds of people who get vaccines and get benefit out of it. So that's always a background, and there has always been skepticism. So people have been slightly not pro for vaccination with flu, but COVID has changed it because of the significant complications associated with COVID, at least in the early phases of the pandemic, when we didn't have vaccines and the risk of the COVID being quite dangerous. But things are slowly settling down. I know we do get loads and loads of new variants. Things are going. There is upcoming winter, and I don't know, I haven't watched the news, but if presumably they might predict that this is going to be the worst winter. They do say that every year, but and obviously the respiratory viral infections are quite an important thing to be aware of. So that's sort of a backdrop so that we can discuss the questions you have kindly asked, and Sam, I think, is going to sort of systematically go through. And obviously, since it's not a big crowd, if Sam agrees, happy to be stopped in between and chip in with questions and things as they come up. So again, I think the direct answer to that question is, I would say yes, because we don't know. We don't know this year how the variant and how the behavior of the COVID is going to manifest. But it also depends upon sort of weighing up. It's not like an absolute 100% yes, go for the vaccine like last year or the year before. We would say, but it's about weighing up the benefits and risks as well. So what we are hearing is that yes, there was definitely an increase in the cases in the last month or so, different variants as well. But it seems to be that the manifestation of COVID in at least people not over the age of 60, 70 has been quite on the milder spectrum from the pneumonia side of things. So the chest infections from the COVID, it's been a bit on the on the milder side. So I'm saying that with a bit of skepticism as well, because we are still going into a territory of how these variants will evolve as well. So I think at least this winter, if there is no other contraindications, and I know, as Sam said, everybody has had, I don't know, between 5 to 8 vaccines already. So I would say it might be it might be safer. And as people might know, I think there's only one vaccine which is generally being used. Obviously, correct me if I'm wrong in this. I think at the moment there is only the Moderna vaccine, which is teed up to the COVID variant to be given. As you probably knew, the other vaccines like the AstraZeneca and other things, there were some specific complications, which is hence it's not been much used in UK. So at least because do you remember when we had this discussion maybe a year or 2 years back? Which one should I choose? Would I go for the Pfizer? Would I choose for the AstraZeneca or the Moderna, or AstraZeneca or Oxford or the Moderna vaccine? So I can see there is offering Pfizer there. So but predominantly it's been Moderna, but Pfizer, as you say, has been used as well. So generally, I would say yes is what I would say if there is no other contraindication and you're not significantly concerned because you've had a few vaccines given already and you're not worried about the side effects and you feel a bit safer having the vaccine. So I would say yes. Yeah. Okay, so if I understand right, so previous reactions were prior to the diagnosis of aplastic
Yes.
anemia PNH.
Yes.
Yeah. Okay. Uh, yeah, so that's a slightly unique situation, which is where I was telling you again, everybody needs to discuss about it in a individual manner as well. So there is always the concern that if you've had reactions before, will you have reactions again as well? In particular, at this moment, if you're having aplastic anemia and PNH, it also depends upon whether John, your wife, is having any treatments for that as well. Yeah, because sometimes when you are on big doses of immunosuppression, like an ATG or cyclosporin, which is used commonly for aplastic anemia, number one is patients might not respond as appropriately within the first 6 months of the ATG and high dose cyclosporin. So that's number one. So if you're within that time period, then it's potentially better to delay it. One, because you will not respond. Number two is you don't want to have the false reassurance. Yeah, I've had the vaccine. I'll be good. I'll be fine, and find that you're not because your immune system is so much down that, or your wife's immune system is so much down that they're not responding to the vaccination. But if you're not, or if your wife is not on those treatments at this stage, then I think it's balancing out. And then I agree that there is a concern, which is why I'd say some people also say if I've had a few vaccines, yeah, my immunity will be there to a degree. Number two is if I've had a previous COVID, because having a COVID infection always gives you a natural immunity because you have had a COVID. So those might play a factor as well. That will help you to decide, yeah, I've had a few vaccines, I've had some degree of immunity, I've had a COVID, I have some immunity. Let me see how things pan out. If we are going to have another sort of pandemic proportion of COVID this winter, then that's a different reason at that time. Yeah. What we have not touched upon is something which we always use in all these things, something called herd immunity, because you're technically protected because if a larger proportion of the population have had vaccines or infection, you have built up the antibody, so that will help to prevent other people from getting that. So, which is a very well-known concept in vaccination as well, that the population around you is protected, then there is likelihood that you are protected as well. At least you've asked a question where I can be very categorical and dogmatic and don't I'm not going to give iffy answers because the data is very strong, which is fantastic in the sense like, yes, so the Leeds team, which is another PNH center, did a large data analysis. I can't remember the numbers now, but a very substantial number of patients, about 300 odd, if I'm not wrong, who had either aplastic anemia or PNH, aplastic anemia who've been treated in the past, aplastic anemia who are currently treated, aplastic anemia on cyclosporin, PNH not treated, PNH on all the drug treatments. And reassuringly, what was found was that a big proportion of patients, not dissimilar to population average, close to 90%, had a very good response. When I say that immune response, that you produce the antibody against the vaccine so that you have a protective antibody levels due to the vaccination, which helps. And so that is very, very reassuring. Prior to that, we did a very small study, which also showed not a dissimilar thing, but we also did it in a condition like myelodysplastic syndrome, where the response was not that high. It was close to the 70% mark, not like what we saw in the lead study. Around 80 to 90%, close to 90%, had a very good response to the vaccination. And subsequently, we also did another study through the European Bone Marrow Transplant Aplastic Anemia Working Party with a large group of patients. The question asked there was to see, has vaccine triggered relapse of aplastic anemia or worsening of PNH? And I think the answer for that was that the vaccinations in most, if not all of those patients, did not deleteriously trigger a relapse of the aplastic anemia, i.e. the blood counts did not go down. There were a few patients who had a bit of hemolysis after vaccination, which we do see, but essentially the question around aplastic anemia relapsing after vaccination was, I wouldn't say put to bed, but at least reassured to note that none of those patients in the study had worsening of the blood counts following vaccination. Yeah, I think I think this is more of a pragmatic answer. That I never do two things at the same time, because you never know what is causing what side effect as well. I know you need to have one in the one arm and the other in the other arm, and if it's more sore in one arm, then the vaccine is creating a bit of trouble. But I would personally think spacing it out is always good. Yeah, there is no data to suggest that your immune response is going to be higher if you pair it up and give it at the same day in two separate arms. Yeah, I think it's probably pragmatically convenient, but I would separate it out, because if there was any complication of side effect, at least you can identify that which vaccine was the one which was causing the culprit. So I would suggest that separating out is always a good thing to do. I think for people who are non-severe, who don't have severe abnormal blood counts and are not on active any treatment like cyclosporin, I would follow the policy for that person appropriate for the age. Yeah, if it is recommended by the government and the Green Book for people who have flu vaccination, who are supposed to have flu vaccination, I would have it. But if they're 20 or 30 and they otherwise have a normal active lifestyle and don't have any complications, then I don't think so. There is a big necessity that that person needs to have the flu vaccine. So I had to do some digging around. I didn't know the interaction. There is. Then I looked up and read a couple of articles as well. So it does interact with cyclosporin. So the advice has been to either withhold the cyclosporin for a transient period and have the Paxlovid, which is only for 5 days, and then restart the cyclosporin if that is allowed. Allowed in the context of your local team, happy to withhold cyclosporin for a transient period of time, which sometimes we do. If we do withhold cyclosporin, if you get too higher levels or the kidneys are misbehaving. So we do it not uncommonly. So withholding it for a particular period of time is not I don't think so it's a major downside. So because of the interactions, and quite a lot of immunosuppressions do have interactions as well. So uh, the alternate treatments, unfortunately, quite a lot of the alternate treatments are not particularly effective against the Omicron variant. There are newer things which are coming up as well, but as far as I know, there are alternatives, but not as effective against the Omicron variant as you would for as using a Paxlovid. So probably withholding for a few days and going on to treatment is, if allowed, is probably the advice I would be doing. And obviously, in those special scenarios, we'll always discuss with the team who are treating for the COVID, the COVID medicines delivery unit, which has been a bit slightly defunct nowadays, but from those group of people to understand whether any other treatments are there and weigh up the risk benefits of one treatment versus the other in the context of somebody being on cyclosporin. Yeah, yes, I think Irene is on the call. I think so. I said, yeah, I've not seen Irene for many years, so it's good to see you. Uh, yes, because once you have transplant, although your immune system is slowly, steadily recovering and slowly getting better and getting used to the new thing, you are technically classed as sort of somebody whose immune system who's clinically vulnerable or immune suppressed, because it's not just because your spleen, which is one of the organs which removes a number of bacteria and other infections, does have a less function after transplant as well. So that's one other reason I think it's better and safer to be classed as clinically vulnerable. I don't know whether we are allowed to use that terminology nowadays or whether it's been used, or immunocompromised at least, or immunosuppressed, and would definitely be eligible for COVID treatments. Yeah, I think it's always great to be sensible and be careful about oneself, because we need to look after ourselves. I think the best masks are definitely the FFP3 masks, not the surgical masks which are always floating around in the hospitals and everybody wears it. So I think the masks, FFP3 masks, are always quite helpful as well. One of the things we've talked about before as well is that, like, I think mask wearing is all good, but it's all about, because technically and paradoxically, if you wear a mask, you're not giving it to others, but it doesn't stop significantly from others, because technically if somebody is having symptoms of flu, they should be the one wearing the mask rather than the other person, because you're stopping it from going, type of thing. But as a general dictum, I would suggest that if you're going sort of out and you're worried about things, wearing a mask is better, preferably the FFP3 masks or the FFP2 masks rather than the surgical masks. Again, that all depends upon the person and the personality and how risk averse one is as well, because you we all have to live our lives as well, and so there is a balance as well. Sorry, I'm just getting a bit philosophical, but that's not what I meant to say. But again, large gatherings is always better to avoid. Yeah, but if there is a need for it to go, it's always good to go. But having masks and other precautions is always, if you're seeing somebody obviously coughing and spluttering, you would want to move away from them, because these respiratory viruses transmit quite effectively and quite quickly as well. So definitely, if you're able to prevent it, I would do it and wear masks in those large gatherings to prevent you from getting it. But I think this winter will be a good one to see how the variants and how COVID goes, because if the peak is going to go down and less worrisome, then hopefully, I don't know, we might see the see the fag end of it over a period of many, many years, but at least you won't have the significant spikes. Probably wouldn't. I think so, Sam. In this scenario, an answer to Nikki's question as well. But I think it all depends upon, because we're still, I think the sun was still shining a couple of weeks back, is it? So I think we're still in the early phases, and we don't know how these variants behave and what the pattern is, and that might decide how cautionary one has to be, going from the right extreme to totally isolating and not mingling type of thing, versus sort of being sensible and wearing masks when you go out type of thing as well, and avoiding people with all the usual infections. So I think the pattern, touchwood, for now has been reasonably okay. Yes, there are variants, there are things going around, but it doesn't seem okay. Technically, being in hospital, I'm not seeing a ward full of COVID patients or getting it. So it's not like what we were used to seeing before. We've definitely not seen the back of it, but it is question of how this winter could behave, and that could determine how things go over the next few years as well. Yeah, it can do, because all vaccines, they work by stimulating the immune system to produce the appropriate amount of protection with antibodies and other things. So it's not uncommon that it can trigger these things, but the main thing is hopefully they are very transient. So it's a sensible thing to do a blood test before if it's possible to do a blood test before the vaccine, and also do one a couple of weeks later, just to be for a reassurance aspect as well. And if it is bit down, obviously you would want to repeat it, and don't want it to be more than a transient phenomenon. So this has been shown before as well, that the blood counts can take a bit of a dip, but most of the time it can recover as well. Yeah, I think one of the things which always impacts on the risk for any of these things, be it COVID, be it flu, fundamentally number one is age. Yeah, unfortunately, the older the people are, there is a risk of more complications. The second is also what we call it as comorbidities, i.e., what are the medical conditions that person has got. Yeah. So so if they've got a diabetes or a heart condition or other things, that increases the risk of it. I think the thirdly is the underlying immune system. So it's a question is, if the blood counts are perfectly normal, but it's a question is, if the same patient has had previous immunosuppression, then there is some degree of reduced immune system, which with tiny bit put somebody at a slightly increased risk compared to the other person who's of the same age, who doesn't have aplastic anemia. Yeah. So age, existing other medical conditions determine most of it. Actively on immunosuppressive drugs like cyclosporin and ATG does increase the risk as well. Yeah. I think neutrophil count, and you guys, the people here are very much aware of neutrophil count because of the aplastic anemia. So neutrophil count is definitely a very good and one indicator which we always feel happy about, both patients and the doctors, and everybody feels happy about. So absolutely, if we take it, neutrophil count of 1 is taken as a cutoff to say somebody is neutropenic or not neutropenic. But anything more than 0.5 is also a good level. But it's also important that if you're somebody whose neutrophil count is slowly going up, if you're on an active treatment, that is also, the trend is also a good one to look at, and it's the neutrophil count. But neutrophil count is not just the one and only thing, because as we all know, there are 5 different types of white cells. There are lymphocytes and other types of cells as well, which also do play a role in providing adequate degree of immunity immunity for patients. But bottom line is neutrophil count more than 1 is pretty safe. 1 into 10 to the power of 9, they say, or sometimes you might be told by your doctor as it's more than 1,000. So those are the levels which would be relatively safe. Probably not is what we saw in the data, in the sense that having it, because even with patients who were still not had a recovery from their aplastic anemia, they had a good response immunity against the COVID. The flu was not tested in that study. So I think, yes, you would have immunity and protection against it if you have it tiny bit below the normal. So thanks, Sam, for that. So the Shingrix vaccine is against shingles. Yeah. So you might have heard people probably in their 65s and 70s would have heard about the offer of shingles vaccine for people over the age of 70, because shingles can happen in those people just because of your age-related decline in the immune system, which is been well documented before. But the one vaccine which was available for shingles was a live vaccine, which was a 1-dose vaccine. And every hematology patient was told to avoid that vaccine because it's a live vaccine, be it transplant, not transplant, anybody. But in the last few years, there has been another vaccine, which is what Sam has said, which is the Shingrix vaccine, which is a killed vaccine, i.e. inactivated vaccine. So you don't have the live virus, where it's given as a 2 doses, and it's generally recommended for people whose immune system is compromised, people who've had a stem cell transplant, which is what Sam was alluding to, and to have this Shingrix vaccine as a 2 doses to avoid people getting significant shingles over a period of time, and it's protective. What I'm not too sure about is where do patients with aplastic anemia who've not had a stem cell transplant fall into the category. And Sam did mention to me, but I've not read the green book cover to cover to pick up that. But I'm sort of in two minds, because in the sense, like, yes, patients who have aplastic anemia who have been treated with ATG and cyclosporin, their immune system is a bit down than compared to other people. Question is whether you would be better off by having the Shingrix vaccine. I don't think so. I've seen enough data to say yes or no to that. And I know, Catherine, you put in the text as well, if you've had shingles, whether you would need the revaccination. I think that depends upon whether your protective immunity against shingles is still adequately up as well. So if your immunity due to the naturally getting shingles is quite high, then you probably don't need it, because to my knowledge, shingles is not like COVID or flu. It doesn't keep changing every year. So it's only one. But I think happy to look into it a bit more and tell you. But as far as my knowledge goes, if you have protective antibodies due to the shingles itself, then you probably don't need it to be boosted. But the question is, then you need to repeat it again at some point down the line and make sure it's still protective to prevent you from getting shingles again.